Thank you so much, Professor Rosano, for this kind introduction. Good afternoon, everyone. In a couple of minutes, I'm going to give an overview for a very challenging trial for a long time, a great debate, a discussion, ischemia trial. So we know that the primary goals of treatment of chronic coronary syndrome is to improve survival and to improve quality of life. This is the aim. Ischemia trial tested an initiative invasive strategy compared with the conservative strategy for patients with chronic stable angina having evidence of moderate or severe ischemia. And the primary outcome was mainly looking for the major adverse clinical events, 5 components. The secondary outcome is the angina-related quality of life, with an extended follow-up still ongoing, looking mainly for survival. So in short, ischemia trial, this is a design of the study, patients with stable angina, moderate severe ischemia, doing first CT coronary angiography to rule out left main disease, and then those patients who are receiving optimal medical treatment were randomized to conservative strategy versus invasive strategy, in addition to optimal medical treatment. And patients who have left main disease more than 50%, ejection fraction less than 35%, GFR less than 30, ACS within 2 months, severe valvular disease, or unacceptable angina were excluded from this study. What is the difference between ischemia trial and the other trials for patients with chronic stable angina? Those patients are high-risk patients and having angina in the presence of moderate severe ischemia. So compared to the previous trials, Courage and Barry 2D, those patients previously were not considered high-risk patients. And there was a bias in the randomization because those patients were not subjected first to coronary angiography. So many patients with mild to moderate ischemia were included in these trials. In addition, the use of third-generation drug-eluting stents were not used in the previous trials. And ischemia trial is a big trial compared with the other trials. So in summary, of 5,179 patients were randomized to invasive versus conservative strategy. And high-risk patients were included. Look for the severe ischemia. It represented in 54% of those patients. 76% had multivessel disease. 47% have proximal LAD. The invasive strategy used in 80% are revascularized. 75% PCI compared with 26% for CAPG. The conservative strategy, 28% shifted or randomized to invasive strategy if they have an evidence of refractory angina or developed acute coronary event. Optimal medical treatment is the cornerstone in this study. So in addition to lifestyle modification, aggressive level-lowering therapy, proper use of optimal medical treatment, this was mandatory. So keep blood pressure less than 140, LDL at that time less than 70 milligram per deciliter. So the majority used a high-intensity statin to achieve the target LDL. So look for the primary endpoint, which was the composite of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And you can appreciate that this was not statistically significant. However, in the first 2 years, we can see the separation of 2 curves in favor of the conservative strategy due to the high incidence of peri-procedure MI. While after 4 years, the separation of curves in favor for the invasive strategy due to the lower incidence of spontaneous myocardial infarction in the invasive strategy. So again, cardiovascular death or MI, the major secondary outcome was not statistically significant. And they look for all-cause mortality and cardiovascular death also was not statistically significant comparing both strategies, conservative versus invasive strategy. Again, peri-procedure MI was high in patients randomized to invasive strategy, while spontaneous myocardial infarction was high in patients who were randomized to conservative strategy. But importantly, patients who were randomized to invasive strategy had the lower score for angina. So at 3 months, 12 months, and 36 months, angina relief and the score for angina improved significantly in patients who were randomized to the invasive strategy. Then we followed up those patients, and ischemia extended trial was published last year, and the median follow-up was 5.7 years. And looking mainly for survival, because with the long-term follow-up, you can appreciate and you can see a new data indicating the superiority of each strategy on the long term of the study. So look for after 3.2 years median follow-up, the mortality 289, additional mortality during the extended follow-up 268, and the total mortality was 557. So look for the all-cause mortality. Again, there was no statistically significant difference between both arms in terms of all-cause death. While cardiovascular death, interestingly, was to be more significant, lower in the invasive arm compared with the conservative strategy. And interestingly, non-cardiovascular death was more and significant in patients who were randomized to the invasive strategy compared with the conservative strategy. And as demonstrated in the original study, that there was no heterogeneity in the results, which means that the outcome was the same, whether patients, whatever the drugs used, whatever the severity of ischemia, moderate or severe, whatever the presence or absence of LAD, so there was no heterogeneity in the results regarding all-cause death, cardiovascular death, and non-cardiovascular death. So look, for example, for all-cause death in the presence or absence of multi-vessel disease, the outcome was the same. And for cardiovascular death, the same outcome in patients with multi-vessel disease and no multi-vessel disease. So again, the ischemia extended study did not demonstrate a difference, whatever the sub-study analysis. So they concluded that extended follow-up of ischemia, randomized trial over a median 5.7 years, demonstrated that initial invasive strategy compared with an initial conservative strategy resulted in no difference in all-cause mortality. However, they demonstrated a lower risk of cardiovascular mortality, but higher risk of non-cardiovascular mortality. What are the implications of this? The implications that these findings provide evidence for patients with chronic coronary disease and their physicians as they decide whether to add invasive management to guideline-directed medical therapy or not. And now the follow-up study is ongoing, which is expected to be up to 10 years follow-up, like STITCH trial, extended long-term follow-up to see the difference between invasive strategy and the conservative strategy in patients with chronic stable angina. And this ischemia extend, which was published in Circulation, and we have the honor to be part of the ischemia trial, cardiology department at Cairo University, one of the sites which participated, and I am the PI in the Cairo University site in the ischemia trial. So look for the difference between studies. Orbita 2 was published in American Heart. Does PCI without anti-angina medication improve angina compared to placebo? Look for the results. Yes, the study was positive that PCI improved angina symptom score compared with placebo, but in this study without the use of anti-angina drugs. And they concluded in this study that in stable angina, evidence of ischemia without anti-angina medication, PCI improved angina, reduced angina frequency, increased exercise capacity, improved quality of life. This effect was immediate, sustained over 1 year, over 12 weeks, consistent across endpoints, but it is a small study compared to others. So how to manage those patients who have chronic stable angina with an obstructive coronary artery disease, 50% or more, ejection fraction more than 35%, optimal medical treatment is the cornerstone. And this is very important, to titrate the drugs, to use the drugs which have an evidence to relieve angina and improve symptoms and improve quality of life, cardiovascular prevention and anti-angina therapy. In the presence of left main disease, of course, those patients should be subjected to invasive strategy with or without the use of hemodynamic assessment in the cath lab, and revascularization is indicated. And after doing the non-invasive investigation to detect the severity of ischemia, moderate or severe, mild or no ischemia, in the presence of moderate or severe ischemia, and the angina not responding to optimal medical treatment, those patients should be subjected to invasive strategy. So the American Heart Association ACC guidelines last year recommended class 1A in patients with refractory angina despite medical therapy and with significant coronary artery stenosis amenable to revascularization. Revascularization is recommended to improve symptoms. Again, this is my team who participated in this landmark study ISCHEMIA trial. Thank you for your attention.